Hello, everyone. Hi. Welcome to our February SME webinar. Got a good few number of people coming in. We're just waiting for the others. Right. So today's webinar is going to be about becoming a GP in the UK. Now, this is something I personally want to do, and I know a lot of other people want to do it as well because it's just such a desirable job and demanding. So today your hosts are going to be myself, Mohsen Salim. I think my name is written above me somewhere, and Raza Khan, who's just going to be in the background. Right, let's see if I can work this. Okay, great. So this is the welcome. And again, Raza was supposed to be here, but I just jump in. And just shortly, I'm going to pass it over to Dr. Rasheed, who is a GP principal at 3 GPs in and around Essex. And she's got a lot to contribute. So I'm really looking forward to her talk. You guys are really going to enjoy that. After it's going to be Dr. Salako. Now, Dr. Salako is a GP trainer. So this is quite good because it gives us a different perspective in terms of, what it's like going through the GP training program. So, because that's something anyone who wants to become a GP has to do. So it's always best coming from a trainer as well as a GP, as well as a GP trainee. And then at the end, we have about half an hour or about 40 minutes for our open Q&A. So in terms of questions, what to do is during the webinar, just keep typing up your questions wherever they are, and if it's aimed directly at either Dr. Rasheed or Dr. Salako, just write their names in brackets beside your question. What I'm going to be doing is I'm just going to be taking notes of the questions because obviously there's a lot of us here today and we won't manage to get through all of them. So I'll be taking notes of the better questions, and at the end I'll just mediate the questions in the open Q&A. Okay, now I'm sure everybody read the summary. This is just a rough guide in terms of some of the things we'll be covering. So steps for medical students, life as a GP in the UK, becoming a GP partner, personal advice, and from Dr. Salako, who's a GP trainer, selection criteria, GP training, career progression, special interests, so on and so forth. And I think the biggest thing is both of them coming together to give you personal advice in terms of things you should do, things they wish they did, things they did and they were happy about, and as you can see, they just have extremely long qualifications after their name, which I don't know what half of them mean, but it's quite up there. Right. Just before we move on, I want to say a quick big thank you to our sponsors, Lectorio. So at the end of this, I'm going to be giving out a code that will give everybody 50% off a 1-year plan with Lectorio, and that will be available for the next 24 hours, which is great. And we're also going to be doing a handout. So Lectorio gave us some 6-month membership passes just to hand out. So they're codes, and I'll explain how I'm going to hand them out later on. But we've got quite a few of them, so I'm actually looking forward to getting around to that. Right, yo. I'm going to pass it along to Dr. Rasheed. I'll just stop sharing my screen.
Wonderful. Excellent. So while Mohsen is getting my slides ready, welcome to today's talk. And I wanted to thank SME for giving me this opportunity. I've known Aris for a very, very long time. And my own daughter is studying in Bulgaria, and I thought Mohsen contacted me, and I think we all owe him thanks for badgering me into doing this. I wanted to talk to you about general practice in the UK today and in the future. Now, I know a lot of you are very interested in becoming GPs, so I thought this would be a great opportunity to start not just one lecture, but hopefully a series of lectures where we could bring together for you people that can bring an insight to you of what it is to become, what it is to be a practicing GP in the UK, and what is a GP today, and what does the future hold for you. And I think that's very important. And the reason I called today's talk Today in the Future is that when I became a GP about 25 years ago, I have never seen, I mean, this has been simply unprecedented change. I have never seen the pace of change that we now see in primary care in the UK. 25 years ago, the job was completely different from what it is now. And I think yourselves as young medics who are about to embark on career choices in medicine, you need to factor a lot of these things in. And I did mention this to Mohsin, and I did mention it to Aris, that what we need is a series of lectures where we can talk about how the NHS is progressing, because I would imagine that a lot of you would be coming back to your families, back to the UK, and looking to practice and to get into training in the UK. So let's, without much delay, let's start with the first slide. Could you put on the next slide, Raza Mohsin? Thank you. This first slide is quite interesting, and it's a high-level slide, but I just want you to understand that the amount of budgets that are flowing through the NHS, and they are quite considerable. So the Department of Health and Social Care gets a £130 billion budget, of which NHS England manages to get 112. The rest goes towards social care. And only about, originally, only about 7 to 8% of the NHS budget was coming towards primary care. As you can see in my slide, the vast majority of it goes to clinical commissioning groups to buy secondary care. So by secondary care, we mean NHS hospital trusts. So you can imagine that the amount of money that's going from the NHS into primary care is very, very small compared to the amount of money that's going towards hospital care. So the starting point of all of this is that primary care is actually very poorly funded. And in the last few years, the primary care funding has slowly and gradually gone up. And just this year, the government has had to, because of the COVID crisis, put a little additional funding into the NHS. So contrary to what people think, that GPs are actually the big earners in the NHS, they're actually the poorest provided by the NHS in terms of the care that they deliver. So on an average, in the last year, GPs have delivered something like 300 million consultations in comparison to about 23 million attendances to A&E. So it's widely recognized that in the NHS, the GPs, they are the gatekeepers of the NHS. And if the primary care were to collapse, then hospital medicine would certainly collapse. So GPs perform a very, very important function. Can I have the next slide, please, Mohsin? So how, I mean, you'll obviously want to understand, you know, how does primary care work? So as I said to you, one of the great challenges within the NHS now are the financial constraints that are there within the NHS. We've had a more recent increase in the funding, but it is difficult for me in one lecture to be able to explain to you how primary care operates. It's very, very complex. There are different operating frameworks. And at the end of the day, they all have to integrate to give a good outcome. What you need to understand is payment to GPs is outcome driven. It's actually payment by results. And later on in the slides, I'll begin to develop your understanding of how GPs are actually paid, because I know that's a very important consideration for all the young people that want to go into general practice training. And it's important also to understand the history of the NHS, its development, its evolution. And primary care is actually vast, and it's a very challenging, it's a very exciting time in general practice. And the reason is that the government has recognized the huge importance of primary care, and it's actually looking to change it. But rather than people think that primary care is a specialty which is quite limited because you're not dealing with complex heart surgery or brain surgery, it's actually very vast, and GPs will treat anything from dermatology to psychiatry to neurology to ENT. So if you want to be a GP, you have to be prepared for lifelong learning. Next slide, please, Mohsin. So Mohsin and I discussed how to frame this talk for you, and his consideration was that how can I make you all be better prepared to enter into general practice training within the UK. Now, I teach medical students from Imperial College, Anglia Ruskin, and Brighton and Sussex University. So we have students coming into our practice throughout the year. And I think if you want to, because you will all go and do your foundation training, and those of you who are coming from Bulgaria and the EU, you would have already done your FY1. So you would be competing for an FY2 post, and then you have to go into your GP specialist training, your ST training. And I know from some colleagues and other junior doctors who I have mentored over the past years that it's becoming increasingly competitive. So whereas at one side of the equation, we like to say that we want more GPs and we want to recruit more, I can assure you that the recruitment is not easy. So there is, and Dr. Salako will elaborate further on this, what we are looking for are really very, very good doctors. And naturally, you'll all be competing both with each other and with entrants in the UK. It's becoming quite a popular career choice for people. So I think going forwards, all of you need to be prepared as to how you can, or what you can do for your CV and your training to make you desirable when you actually go to the interview. And I would say that you should form a GP forum for medical students to engage with like-minded students so that you can focus on your chosen career path. Another thing I would strongly recommend is to look for a UK clinical attachment in your holidays in a teaching practice. So I think you should do a mirror image of what students do in the UK. So that's 12 weeks if it's possible. So you should do 4 weeks in third year, fourth year, and final year. This is what most of our medical students in the UK do. And then you could write articles, you could, demonstrate teamwork, because nobody in primary care is now working alone. We all work as a part of a large team. It's also useful to be able to do some community work to show your interviewers you genuinely care for people. And I think one of the things that a lot of the people that are studying abroad don't understand or don't appreciate is you need to get on to the GMC website. On the GMC websites, there are some absolute key documents, especially guidelines for good medical practice, to appreciate that there's a very strong ethical framework for doctors in the UK. And you do need to recognize, and I say this to my own students, that you need to recognize your own limits and build a support network of peers and mentors. This is not just to support your mental health as a student, but also to build support for not just lifelong learning, but lifelong changes and pressures that you will be facing. Because general practice is actually quite a tough field to be working in. It's absolutely frontline. And in many ways, you are not as well protected within a large hospital trust if you were working in a specialty like surgery or general medicine, or you were going for a more hospital-based specialty. Those jobs are actually very well buttressed, and you're very well protected by all the specialities and the investigations and all the advantages that you get from working within a hospital. When you're working in the community, you really need to be a very, very good doctor. You need to be very good with your history taking, your communication skills, and your general medicine, geriatric medicine. So rather than what people might think, the general practice is a soft option, actually it's one of the hardest options, because primary care is a specialty in itself. It's a specialism. It's not, it's a generalist specialism, and that is actually recognized in Europe. And even as a GP, you will be getting onto your own specialist register, which is the register of GPs. So rather than think that this is a soft option and it's going to be a doddle, let me dissuade you of that idea, because general practice is a very, very tough playing field. Can I have the next slide, please, Mohsin? Now, Obviously, Mohsin wanted me to talk, and this is it's quite a big topic, and he wanted me to talk to you about job roles for GPs. Now, GPs are independent contractors if they choose to be, and in one form or another, whether you're salaried or you're working through a partnership or you're working through a single-handed model, you will in the future be holding some kind of an NHS contract. And there are, broadly speaking, 3 kinds of contracts. And these are all what we call block contracts. And I'll explain that. A GMS contract is a general medical services contract, and it is nationally negotiated by the GPC, which is the General Practitioners Committee of the BMA, and that is the doctors' union. So on a yearly basis, the representatives of the doctors, they go in and they sit in a huddle in a room, and they sit and they negotiate with the government, and literally we fight for pennies. The other type of contract is a PMS and an APMS contract, and these are personal medical services contracts. And they are short-term, short-lived, but they're actually more lucrative. Having said that, there's another kind of contract which we use in contracting with secondary care, and those are tariff-based contracts. Those are known as PBR, or payment by results, and these are performance-based contracts. So you need to understand that when you become a GP, you will be working in some kind of a performance framework. So whether it is the hospital, which the GPs will hold to account, or it is working for yourself as a GP, your taskmaster and your commissioner, which is the NHS, will be holding you to account for some very, very strict targets. And this is what we call KPIs. These are known as key performance indicators. Can I have the next slide, please, Mohsin? Minu, take it away. So Mohsin has asked me to speak to you about the different types of GP roles. So by and large, Dr. Salako will explain to you how to get into GP training, but by and large, GPs are either salaried, which means that they are either working in a salaried position for a larger partnership which holds a contract, or they are, and we're seeing this more and more, we are seeing salary GPs for the first 5 years. They can apply for fellowships positions, which allows them to go and study for a higher academic degree. And those people who want to just go straight into business, they can go and become GP partners in a large partnership, which doesn't necessarily mean that they become senior partners. Or they can become portfolio GPs, which means they can be salaried, they can be self-employed. At the same time, they can be doing 5 or 6 different roles. We also know the GP commissioners, they serve on the boards of CCGs, which is a very powerful politically active position. GPs are clinical directors of primary care networks. They can become medical directors employed by larger providers, or they can become academic GPs. They can work with universities as lecturers, professors. Some of our GP colleagues, they are involved in journalism, medical writing, and of course then there's private GP services. So these are GPs that provide private primary care for companies. They do medicals, cosmetic services, sexual health, and all sorts of provision that is not necessarily under the NHS. And we know that more and more provision is now being delivered in the private sector, and perhaps there is a niche market in there for those of our colleagues that are entrepreneurial and would want to go into this. There's a real market out there for private GP services. Next slide, please, Mohsin. Now, how can you hold a contract for provision in primary care? So there are different business models. You can be a single-handed GP as one GP holding the entire contract, and that is quite a risky prospect. So I am, for example, a single-handed GP. You'll talk to Dr. Salako after me. He's one of my very beloved colleagues, and he's a partner in a very large multi-practice model. And the advantage of being single-handed is that you're pretty much a singular boss, but then you hold a lot of financial risk because these are very expensive NHS contracts, and if you default on them, then there are penalties, and then you carry the financial risk on your own. Those of the GPs that work in partnership model, there's some pros and there's some cons in them. Generally, the partnership model is the model of the future. It is not a desirable thing to be a single-handed GP. And I can say that with no hesitation that I was briefly in a partnership, and I think that was wonderful to be in a partnership. But it's really important to be with like-minded people. And then there's another model in which private companies can hold an NHS contract. And these are regarded by the NHS as very risky. So say if 4 GPs got together, formed a private company and tried to hold a GMS contract, then because companies have limited liability, the government will ask you to put something like £2 to £3 million down in a bank account as indemnity. And the same GP contracts, they can be held by anybody, NHS trusts, community trusts, mental health trusts. The government experimented with that for some years. About 10 years ago, the government experimented with that. But they also realized that when they brought in private companies or NHS trusts to hold primary care contracts, they were not very profitable or lucrative. So these contracts were then given back. So we are now seeing a return back to the old GMS model. Thank you. Can I have the next slide, please? Now, as the pressures are mounting in general practice and we are not getting enough recruitment, GPs are being asked by the NHS to work in larger, loose collaborative networks of 10, 15 or 20 practices, and that is known as a primary care network. And we work with devolved NHS budgets to provide services at scale. And very much the direction of the future, which I can see on the horizon, is that these primary care networks are actually going to become the future model of general practice working. We also have GPs working in what are called GP federations, and these are our provider organizations. And that enables the GPs to provide outside of their GMS contracts, and then they are able to share the profits. Going forwards, the government wants to, so before Brexit, round about the time of when Margaret Thatcher brought in the purchaser-provider split into the NHS, separate budgets were created both for primary care and secondary care. The government is now going back to an old-fashioned, new-fashioned model, which they call integrated care organizations, which is going to hold pooled budgets with representatives from primary care, social care, acute trust, sitting on these very, very large boards, but they are going to be able to hold each other to account because the budgets are actually going to be pooled. And I think that's a very exciting time for the NHS. And this is what I was trying to say to my young colleagues that are now coming into general practice training, is that we would like to see you, young people, prepare for a different future from the present that we are living in. Can I have the next slide, please? So, the question we want to ask is, why do I want to be a GP? So if I look at my own self, I used to be a hospital doctor, and I'm a trained gynecologist, and I spent about 17 years doing obstetrics and gynae. But for family reasons, I became a GP, and I have never looked back because I have found not just general practice is more flexible. It allows part-time working. It gives you the advantage of self-employment. And for people who are training in general practice as a terminal career, as the career path that they choose, it is probably the shortest training time that you can have. Whereas if you were to go into a surgical field, the acquisition of surgical skills is quite a challenge, and it can take, it requires very good physical and mental health, and it needs a very long career path. So for a lot of people, general practice is absolutely perfect because it gives you flexibility, part-time working, you can become a portfolio GP. There are some disadvantages, and I won't lie to you. We all work very, very long hours. So I get into work at 7 a.m. and I don't leave before 7 because there's a lot of paperwork, there's a lot of bureaucracy. And no doubt, being a partner, there's a lot of financial uncertainty. And the reason I say it's uncertain is because the NHS loves to change. And every time because it's a closed budget, and you have to operate within a pretty rigid financial envelope. So most GP partners at present, they are not absolutely clear at the end of the year or by the end of the month what their profits or their drawings are. So a lot of GP partners actually do a little bit of work outside of their own practices because they just need that little bit of buffer. And no doubt, I mean, one of the things that GPs face is we face a lot of medical legal risk. And the reason I say we face a lot of medical legal risk is we're frontline workers and we see undifferentiated patients. So by the time I would see somebody with abdominal pain, that I would then triage and consider that they might have an appendicitis or they might have a ruptured ovarian cyst, and I send them to the hospital, I would have done a lot of baseline investigations. So GPs not just do episodic care, we do a lot of chronic disease management. And litigation is quite high in primary care because no doubt with the volume of consultations and the number of, if you say 300 million consultations are done by GPs in a year, collectively in the UK, we will miss a few diagnoses, we'll have complaints. There will be patients we see that 3 days later, they'll end up in hospital with, a surgical problem or a medical problem, which with the retrospective scope, it's easy to say that, yes, that is how it should have been. And that creates a lot of work and family pressure. So to be able to understand that, it's not all a bed of roses, it's actually it's a tough life, but it's a very rewarding, it's a very satisfying, it's a very holistic way of looking after the patients. My colleague, Dr. Salako, is an extremely popular GP, and I know, because I sometimes look after his patients, that his patients actually probably think he's like a god. They love him so much that if I said to him, no, you have to wait 4 weeks to see Dr. Salako, they'll be fine. That'll be just fine because they will refuse to see anybody else. So the kind of love that patients have for their GPs is enormous. There's a lot of respect in the community. And if you compare hospital doctors to primary care doctors, GPs are beloved of their patients. They're absolutely passionate about primary care, and you really get an opportunity to form that bond with your patients and to be able to look after not just the patient and episodic care, but literally the whole family. So I think sometimes when I come home, their stories are in my head. I know everything that there is to know about somebody, their family, their problems. And when they come to the GP, because the trust is so high, they will tell you everything. That is an extremely privileged position. It is such a gift in today's day and age to be able to, garner that kind of love and confidence in a patient. I think it's something absolutely unique, and I think hospital doctors miss out on that because they just don't get the opportunity to form that kind of bond with their patients. So I think if you look money-wise, monetarily, I don't think GPs make more or less than hospital doctors, but there is a certain charm, there is a certain flavor in general practice that you cannot get in hospital medicine. And I'm somebody that did half and half. I did half of hospital medicine, then I decided to become a GP. And I never looked back. And in fact, becoming a GP made me a better doctor. So personally, from my own personal experience, I have never regretted my choice of becoming a GP. Can I have the next slide, please, Mohsin? Is that it?
I think that's all Mohsin, of it.
Thank you. Then that's Dr. Salako now, Mohsin.
Okay, Dr. Rasheed, thank you so much for that. That was really enlightening. A lot we don't know, obviously. And we are absolutely working towards, me and Dr. Rasheed, trying to open up something, trying to open up a primary care society of a sort, and just push things like these out there in our community altogether, because, this is the type of stuff we actually need. So, it's just a collective and a collection of us coming together and chasing this knowledge and sharing this knowledge. So it's definitely in the plans, and it's going to be out soon. I'm going to pass it over to Dr. Salako because I'm really excited to hear him speak. So if he's there, Dr. Salako, can you hear us?
And thank you, Mohsin and Dr. Rasheed, for asking me to do this talk. This is my first interaction with study medicine in Europe, and it's a pleasure to be able to contribute. I'm coming at this from when I was asked to do this, I was going to talk about some of the things that Dr. Rasheed has said already, but I'll try and skip over those aspects. But I just thought I'll just give a bit of a historical background into where the idea of general practice came from, and then I'll just walk my way into current day general practice. So I'm gonna press that. Okay, so history dates. It goes back to Africa. There was a war called the Boer Wars in the 1890s, 1870s, 1890s, especially the first Boer War, when they call themselves the Boers, who are descendants of Dutch colonists, moved towards the Orange River in South Africa. So there was a bit of a confrontation then between the colonial powers. Then they found diamond in the around the basins of that Orange River. Of course, this led to conflict, which meant the British had to send army soldiers down that way. Now, then they found that the soldiers didn't do very well. And as part of a review of what happened during the war, British military records show that of about 22,000 soldiers that were killed, only 35% died of enemy action, 65 died from disease, some of including typhoid, malnutrition. A lot of them were declared unfit and couldn't do anything, couldn't contribute to the war effort. So this led to the rulers at that time to start looking at doing something for the populace to improve the well-being of the countrymen. So, of course, at that time, anyone could just do what they liked. There was generalists, there was physicians. Everyone was just doing whatever they liked, and they charged whatever they liked. And in 1911, based on what I just said earlier on, there was a mandate that all working males should be under a general practitioner, so who would look after their health, and they will be paid a capitation fee by the country, by the state. This was extended to all the members of the families in 1948. So that's the wives and the children. The health minister responsible for doing this in 1948 is this gentleman called Aneurin Bevan. He was a Labour Minister for Health, and that's the Act, the NHS Act for 1948, sorry. Moving on. So this led to the birth of the NHS. And on the 5th of July, 1948, Aneurin Bevan stated, and I quote, "This is the biggest single experiment in social services that the world has ever seen and undertaken." And I'm sure you all agree with me. And it has been a huge success. There was this started at the Park Hospital, now called the Trafford General Hospital in Manchester, with 1,143 voluntary hospitals, about 90,000 beds. So that were all, at the end, they had 390 beds in total subsumed into the NHS. General practitioners then were still encouraged to remain self-employed and largely independent. Of course, then that led to the issue of standards. So in 1950, a report in the Lancet showed that there was a large variation in the amount of care that general practitioners were providing to their patients. And this led to the idea of a college that would help to standardize care and make sure that at every time you experience general practice, you get the same quality at all points. In 1962, the college was incorporated, and 1972 was granted the Royal Charter by the HRH Duke of Edinburgh, who's the patron and the president. And in 1992, the Duke of Wales became the patron. So the rules of general practice, some of it Dr. Rasheed has said already. We see about 1 million patients every day in the NHS, and out of this million, 95% of all 95% of all total NHS consultations occur in general practice. So if in general practice, you're going to see geriatrics, elderly care, to social care, to pregnant ladies, to children, newborns, home visits. You're even going to be marriage counselor, name it. That is the role of general practice. A lot of this Dr. Rasheed has spoken about already. We have this new scourge called COVID-19 that has changed everything we do. Now we had to all change within a few weeks into remote consultations, and that has brought with it its own problems as well. And we're also having to vaccinate people against this this scourge. So, but and as you can see, where the country has now reached to almost 20 million people have been vaccinated already, which is a success. It shows how successful general practice has been in enabling this to happen. We provide care from cradle to grave, as Dr. Rasheed said earlier on. You find, if you look at, I just seen the grandchild of somebody you've been treating for the last 20 years, 4 generations at times. And then, of course, this commissioning role, which was placed in the hands of general practice from around 2012 with the government white paper. This kind of just put groups of general practitioners to be involved in commissioning services for the people in that area. And that too has been largely successful because we've been able to sit with our secondary care colleagues and make sure we commission what we need for our patients in an efficient and effective manner. So, so enough of all that. So how do you become a GP? There's this slide which you can all find on the Royal College of GP website. So you go to medical school, then you get your degree, then you graduate, apply for the foundation program. After your FY1, FY2, you then apply for specialty training, which it will then get you into general practice. Still talking about this. Now, the recruitment and selection process. This looks at things like your clinical knowledge and expertise, or whichever expertise you have or experience you've got, capacities to apply your clinical knowledge and awareness to full investigation of problems, your ability to demonstrate empathy and sensitivity. You're going to need a lot of that in general practice. Capacity to self-motivate and to motivate others, and to also listen to other people's perspectives on how things and understand. Communication, it's vital. Without communication, there is no general practice, because most of the things you do is going to be about how you make people understand and carry out what you suggest for them. Capacity to adjust behavior and language as appropriate to needs of different situations. You've just seen a patient who just lost their husband, and then the next minute you're dealing with somebody who's just got a new job. So there's quite a lot of things, but you need to be very flexible. We call something we call housekeeping. You need to learn how to do housekeeping, i.e. to just quickly organize your thoughts and get ready for the next one. Okay. Capacity to think beyond the obvious with analytical and flexible mindset, and also be very open-minded. Coping with pressure. There will be lots of pressure. Capacity to recognize your limitations and develop appropriate coping mechanisms. And that applies to all aspects of medicine. Capacity to organize information time effectively in a planned manner, and also being able to manage and be part and work as part of a team and work effectively with others in partnership. So these are the things that you will be assessed upon at the exam stage or the interview stage. Before, they used to do face-to-face interview, but with COVID, all that has changed now. So you have a written, and then it will now be virtual. So foreign medical graduates, because this is why we're here today. So you need to have evidence of your primary medical qualifications, internship or experience, demonstrate your knowledge of IELTS or English. Then you have to pass PLAB, Part 1 and Part 2. I believe you can do the first part abroad, but the second part you have to do in the United Kingdom. Of course, certificate of good standing, like a reference from your previous employers' activities over 5 years before you applied, declare your fitness to practice. Any documents that are non-English have to be translated. And of course, identity check in the UK. Of course, and then the training program now. So to end up becoming a GP, you must have done 3 years of specialty training. So that would include 18 months in primary care and 18 months in an approved hospital. Yeah. Also, there is an increasing number of 4-year options being available nowadays. So after your 3 years, then you have another year that you can spend doing other things, such as some people do. They call things like you might want to go into commissioning. You might want to anything else that's apart from general practice, just to broaden your experience. Huh? So, but that you just apply for once you join your program. So your program, instead of 3, you will finish after 4 years. Okay, so GP posts, these are undertaken in different primary care settings under the supervision of a GP trainer. Okay, and GP trainers will give you personalized tuition experience and help you go through your 3 years. When you join the program, you will be allocated an educational supervisor who will be with you all through your program, your training. So at the beginning of every post, you have a post meeting, discuss your, you set up your development plans with them, and at the end, you also do a post review in preparation for ARCP. I'll talk to you about what ARCP means in a minute, okay? Now, we have hospital posts. These are also offered as part of the hospital aspect. Now, we have deaneries who run the whole program. So they are the overarching authority over both the hospital aspect and the general practice aspect. So the jobs you do in hospitals will include care of the elderly, pediatrics, O&G, psychiatry, ENT, A&E, dermatology, ophthalmology, palliative care. Some deaneries have also started offering other things like renal medicine, rheumatology, and things as well, just to make it more, just to broaden one's experience. Huh? Okay, now, as I was saying, at least once a year, you have to have something called an ARCP. Okay, usually it's twice a year. The ARCP is as you're approaching the end of your post, this is where somebody just has a look at what you've done, and then they make a recommendation to the deanery whether you're progressing as expected. So the recommendation will be made based on workplace-based assessments, which include COTS. I don't know, I'm not sure whether you're aware of what this, or audio COTS, mini KEXs, CBD, prescribing, quality improvement activities, your basic life support, safeguarding. So KEX means clinical experience. Is where you will probably have like a consultation in front of someone, or carry out a procedure in front of someone, and that is recorded. You're assessed based on your performance. Audio call, you talk to someone on the telephone, and somebody just observes you doing that, and you're assessed based on that. So these are the kind of things we use to to assess your development. Okay. Then, of course, at the end, you will then have to have examinations to get the MRC GP. That's the exit qualification. So prior to get that, you have to have passed the MCQ, also called AKT, And then we used to call it the CSA, Clinical Skills Assessment. That is where you go to the assessment center and you're observed over about 11 cases. You have different patients with different problems, but because of COVID, that has changed. So now that's been replaced by the RCA, which is a recorded consultation assessment. So you will record 10 consultations that you and your supervisor thinks are good. You submit, and then you're marked based on that. As I said earlier on, you also have pastoral care provided by your educational supervisor, who will be in general practice with you throughout your 3 years. They use something called an e-portfolio to monitor your progress. Yeah? Now, general practice also allows you the opportunity to be able to develop areas of special interest. For example, I'm sure Dr. Rasheed mentioned this earlier on, minor surgery. You can you can train up if you're surgically oriented, so you can do lumps, bumps, skin disease, skin pathology. You can do those in your primary care. And then there's women's health, where here you can do coil insertion, you can do implant insertion, you can do menopause care. So areas you can develop. End of life care, work with hospices. This is becoming a very important area of medicine. Dermatology. Some people do work as assistants in hospitals to help with management of dermatological issues. You could be involved in medical education, journalism. There's quite a lot of medical journals. Research is another one you can be involved heavily in. General practice has been at the forefront of the development of the vaccines, so your practice could be at the forefront of that.
Okay, I'm just gonna pop this up here. Rightio. This is it. Right. Okay, so thank you so much to our doctors. We're going to jump very soon into the open Q&A. Just before we do, so again, we're giving out certificates for attendance and the Lectoria discount code. In terms of filling, in order to get any of those, you need to fill in the feedback form. Now, it's not long, it'll take you 2 minutes, and feedback's always good because we're always trying to improve. So yeah, what I'm going to do is I'm going to get Raza to put it down as a question, and then I'm just going to repeat it as an answer. So it's over there, and basically, yeah, just click on the link, fill it out. Alternatively, use the QR code. It's a lot easier if you open your phone camera and just point it at it. It'll just give you a link. So super easy. Again, a big thank you to our sponsors, Lectoria. They've been great, very supportive. They've been handing us out like 6-month free passes, and basically what we're going to do, or what they recommended for us to do, was take everybody's number and they will just randomly select one and get in touch with you and just start throwing free passes and free stuff at you. So it's just a no-brainer. So that's also on the feedback form. Just enter in your number and then we'll just enter into the draw, and we're hoping to pick quite a few people. And yeah, I've been using it for quite a long time actually. I still use Lectorio just to prep for my exams, just for general knowledge. They have tons of clinical cases over there, so it's always helpful. Right, again with the Q&A, just feel free to ask whatever questions you guys want. I've taken note of some. And I'm just gonna hit out our guest presenters with them, and hopefully we can get you guys some answers. Right. So one of the questions were, are there any specific rotations we should aim to do as a junior doctor if we hope to go into GP training?
You see the rotations, once you've done your F1 and F2, which could be whatever, you're free to apply to whichever area of the country you want to work in. So that's at your discretion. Then you apply. Once you get into the program, it is usually what they have available. It will all be kind of pre-populated for you to make sure. The aim is to make sure you're going to be a competent GP, but it's kind of it's all on the shelf. It's a kind of off the shelf things that you will posts that you'll be made to do. So, for example, if you apply to Basildon, because not everyone can be in A&E at the same time. Some people have to do psychiatry, so there might be one or two posts that you may not be able to do. But you can always catch up later on if you need to. Yeah, but the aim is you will still come out as a well-rounded GP.
Amazing. Okay, this next one's really interesting. So if the NHS becomes privatized, how will this affect GPs and general practices all over the UK?
So I'll take that question. We don't anticipate that primary care would entirely be replaced by private general practice. What would most likely happen is that private general practice have always been there in the background, doing the little bits and pieces that mainstream general practice hasn't given to patients. What we don't have is a lot of insurance schemes that are covering primary care problems. So most of the medical insurance you have in the UK covers you for secondary care. So a lot of GPs have taken, and younger GPs who can do cosmetics, Botox, minor surgery, they go and they open their own private practices. There's only one caveat in that when you hold a block contract, you don't make a lot of money. You make some money every month. It's almost like a salary job. If you want to go and do private work, it's probably not going to be mainstream. So you can't rely on that, because if you look at what's happened with COVID, so many people are furloughed, there are bankruptcies, people won't be able to afford it. So it's not something I would advise people to go into core work, but younger people have a lot of ambition and they look for new business avenues. And by all means, I mean, there's a lot of GPs, they do cosmetics, Botox, they do counseling, they have, they have healthcare projects going on. So the future is, you can write your own future as far as that is concerned. But I don't think it'll become mainstream. It'll just make your income more. So I said it will just make your income very unstable if you want to rely on pure general practice. You might make a lot of money if you're in the right place with the right people and the right clientele, but you'll have to actually build a base, which would be problematic.
So the NHS is not going to get privatized?
The NHS, interestingly enough, primary care is already privatized. So if you look, between 15 to 20% of contracts are already held by very large private companies. And if you look in Yahoo today, there was a company called AT Medics that was held by 6 GPs. That has now gone into a subsidiary company of a very, very large American private provider. But then the Transatlantic Trade Treaty that was signed some years ago enables the American healthcare companies to come and bid for services in the NHS. If you look at private healthcare, the Healthcare Corporation of America, HCA, which is one of the largest private care providers, they have bought up all the private hospitals and they control pretty much the entire private surgical, radiological, oncological practice in London. They are now getting into the markets in Manchester and Birmingham. So I think that yes, that is on the table, under the table, that in some shape or form or another, there'll always be that. But one of the things, and I think what the government has done, it's been quite generous in doing this, is what they've tried to do is they've tried to almost force GPs to work in primary care networks and primary care federations. And this is what I was trying to say to the younger people that will now come into general practice. You have to be much, much more astute. You have to be technologically savvy. You'll be even competing with AI, because there are research programs in UCL and all the major London teaching universities looking at the place that artificial intelligence will have in the diagnostic algorithms in primary care. So we are under threat. There is no doubt about it. And change is there. I mean, we before COVID, we didn't have as much technology, and the NHS, because if you look at private medicine in Europe, it's almost saturated. If you look in America, it's entirely private. So the American healthcare industry has been eyeing the 127 billion pound NHS industry for years, and after Brexit, they will have the opportunity. The Transatlantic Trade Treaty allows them anyway, and there are private American healthcare providers everywhere. We have, for example, where we work locally, we have a French company that is doing all our pathology testing. But what I was trying to say to GPs is, gone are the days when you will survive by working alone. Your future will require you to work in large federations and large partnerships of 20, 60, maybe 100 GPs, because unless you federate at that level, you will not be able to compete with the larger, more aggressive providers that are now entering the market. So the future is not that secure, but it will be for those people that can ride the wave and get ahead of the competition. So that's what I was trying to explain. But unless we get into further lectures and I can explain how the NHS is actually evolving, then the way I became a GP, the way Dr. Salako is practicing, that's probably not going to be there in another 20 years. It's going to change, no doubt. I'm quite convinced that to a very large extent, we are on the cusp or the brink of major changes in the NHS.
Thank you so much, Dr. Rasheed. The next question somebody asked, what professional exams would you recommend for us? So the MRCP, for example.
Hello. Yes. As it stands now, you do not need any of that. What you need is to pass the MRCGP, because that's the main. If you want to be a general practitioner, of course, if you want to be a physician, you will move towards the MRCP. If you want to be a gynecologist, it will be the one by the Royal College of Gynecologists, RCOG. Pediatricians have theirs as well. Depends on where you want to go. So, but all this will follow as soon as you start walking. Then you decide you know which way you're going to go, and then you can then do their specialist examinations. But for general practice, it's the MRCGP.
Amazing. Thank you, Dr. Salako. The next question is, a couple of people asked actually, what is the process of for opening your own GP as a GP in the future?
Yeah. Reshma, do you want to do this or should I do it? Because at the moment, it used to be in the olden days that you could just buy a house and then apply to the health authority for recognition, and then you're allowed to open up a general practice there. But now that's all stopped now. So usually you end up joining one that's already in existence, because they're trying to consolidate all the practices available. That's the way things are going. So you qualify and join one that's in existence. That's the way forward.
Okay. So you can't buy a house anymore and just apply for recognition in terms of that at all?
Not at all, unless you're probably somewhere in the Scottish Islands, and I think.
No, because you know the reason Dr. Salako is saying that is that, as I explained, there are these two ways of contracts. The only contracts that continue in perpetuity are GMS contracts, but the service requirements, because you know I didn't talk about the Care Quality Commission, which is our OGA, which monitors general practice. There's the Performance Committee, which monitors GPs at a personal level. And I'm sure Dr. Salako will join me in saying this, that when you look at hospital doctors, their performance is pretty light touch compared to what happens with GPs, because we're independent contractors and we hold contracts for populations and not a few hundred people. our appraisals, our performance management, our care quality inspection visits, etc. They are very onerous and the standards are very, very high. The government is and in fact, it is now becoming impractical to have smaller practices and single-handed GPs. It isn't going to be the way of the future. You're going to be looking at primary care networks actually running core general practice. The government is going to phase us all out. And that is fair enough, because the demand for general practice is so high that it is impossible for a single person to meet their needs. So back before 2004, GPs used to provide 24-hour cover. If you look at Call the Midwife, there's a GP in there that even does home deliveries. And when I first joined my general practice, we had a whole cupboard full of obstetric instruments that I had to remove because we no longer did that. But my senior partners, two of them, one of them is still working with me, they used to do their own home deliveries. They used to do forcepses. They used to do a whole lot. All of that has now gone into specialized secondary care. So what the government is requiring from GPs is geriatric medicine. That's going to become core, keeping people healthy and looking after them at home. And it's not looking for small organizations, because small organizations are very expensive for the government to monitor. What they want is community services the size of an NHS trust. And government has actually been very kind and helpful in forcing GPs to go into primary care networks, because there's no way that even 10, 15, 20 GPs can do what an NHS trust does. So the future now is probably more salaried roles and probably more structures that you would find in community trusts and in acute trusts. So there was a time when there was a model that the government was trying to develop in the UK, and that was vertical integration, where they wanted a primary care department to be created in a local NHS trust and then to take over the performance of all the local GPs. That didn't happen. But they're now experimenting with something called integrated care organizations, ICOs, and that is where your generation will be working in. You will all be working within ICOs in some contractual form or another. That doesn't mean that you can't, because the only advantage you would want to have your own contract is because then you think you'd earn more money, but you could still become portfolio GPs. There is so much scope to do so much in general practice. It's constantly evolving.
Thank you, Dr. Rasheed. The next question, I think, okay, I'm stuck in between two over here. Okay, I'll go with this one first. So the question is, what is I think it's more to do with the concern of how much time you actually get practicing medicine with patients compared to how much time you're doing paperwork. So what is that ratio in terms of you're in from 9 to 5? How much time do you actually spend with patients? How much time are you actually sitting there doing paperwork and documentation? And do you take any work home at the end of the day?
Let me be honest. GPs are paperwork junkies. Okay, we are junkies for paperwork. We love paper. Every day I see something like 300 results, and I will see something like 200 or 300 hospital letters. Now, that doesn't mean you have to do it. What we have now in general practice is we have got AARS teams. These are allied health professionals, physicians associates, advanced nurse practitioners, and pharmacists working with us. We also have HCAs, healthcare assistants, and we have got advanced admin support teams. So a single GP, for example, beneath me, there are a number of doctors, there are a number of pharmacists, physicians associates, advanced nurse practitioners. There's a whole army doing the work. However, because there's some, and this is one of the lectures which I would like to do for you is on clinical governance, is at the end of the day, the accountable officer is the person who holds the contract. So in a single-handed contract, it'll be the GP. In a partnership, it'll be the partnership that holds the clinical accountability for outcome. So if anything goes wrong, no matter how many people are working underneath you as a consultant in the hospital, if you have a team of even 40 people working for you, the senior consultant is the one who the court will hold responsible. So you cannot remove yourself from that responsibility, because medicine is all about responsibility. Medicine is about that personal accountability, organizational accountability, because litigation is very expensive for the NHS. So there is no way that you can get out of ensuring that everything is done, the T's are crossed, the I's are dotted. General practice is not a 9-to-5 job. I beg to correct you. It is a 7-to-7 job. It's a 12-hour job. And any half-decent, hardworking general practitioner will back me up to say it's not a 9-to-5 job. If you're looking for a 9-to-5 job, you probably want to do public health, because even that is probably not a 9-to-5 job. I don't think 9-to-5 jobs exist in the UK anymore. It's a 24/7 culture.
Absolutely.
So, Dr. Rasheed, thank you very much for your input. But not to scare my colleagues, we now have BMA has come up with a junior doctor's contract, which has changed things a lot from when Dr. Rasheed and myself went through training. So when you guys apply for general practice, you will not do more than 35 hours a week. In fact, 40 hours maximum a week. The rules are very strict. In fact, at 5 o'clock, we chase our junior doctors out of the surgery. Just go home, drop everything and go home. That is how strict things are.
Is it possible?
So I just want to reassure you guys that please don't be worried that you're going to be overworked. So things are strict. You'll be doing 9 to 5, but when you qualify, though, if you decide to become an independent GP like Dr. Rasheed and myself, become a principal GP, that it becomes, you cannot do 9 to 5 because the responsibility never ends. Okay, I mean, if you do become a career, there's something called career GPs, salary GPs. They kind of limit their responsibilities, you know. So so there's that possibility. But if you become a principal, then it's going to be difficult. You will still have the choice. Yeah.
Amazing. Regards to salary GPs with fellowship positions, what example of higher degrees can you do? I have no clue what that means. I'm just reading off.
So what we're trying to do is, you see, what it is that when I became a GP, I was kept under supervision with, so for example, in Dr. Salako's practice, he's the chief boss, he's the senior partner. And anybody who joins him is a junior partner. So almost in a sense, Dr. Salako is there as a partner, but he's also this father figure. He also, you know, he's there to support the growth and development of his junior partners. And we now recognize that the training that GPs are getting is not enough to just throw them in at the deep end. So we want people to be bought into this idea of lifelong learning, and we want to give them an opportunity to develop specialized roles. So if somebody has a fellowship and they want to go, for example, and get a master's in healthcare management, that's an option. You could get a year learning to do endoscopies. You'd be pretty much writing your own story as long as that post is funded. But in some areas, and I've seen that in the British Medical Journal, they are giving fellowships which are funded sessions to the salaried doctor to go and, for example, do a diploma in geriatric medicine, or to develop their skills in geriatric medicine. Because one of our challenges for the future is we need a workforce that is fit for purpose. Everything that I learned in my training years was very rudimentary. My own GP was my trainer. And what he taught me was very valuable, but I ended up teaching myself. I went on courses. I did something like 350 hours of CPD last year, because the body of knowledge in general practice is vast. I have to know dermatology, psychiatry, I have to know new drugs, I have to know new procedures, biological agents. So there is such a lot that we need to be able to absorb that we need to be constantly training and learning. But when they're bringing in fellowships, they're actually giving somebody not just a salary job, they're giving them a funded post to go and educate themselves, to spend a little time on rest and recreation, and to grow and develop themselves before they go into full-time general practice, because we're trying to get people with the right skills into general practice.
Absolutely. In terms of contributing to the bigger picture of medicine, how much research do you have the option of getting involved with as a GP?
So some of the practices, like Dr. Salako's practice, participates in a lot of clinical trials. I know that he is a research champion. He can answer that. But there's a primary care research network in Essex, and you can enroll into any number of clinical trials that are applicable to primary care. Dr. Salako will be able to elaborate further on that. And then you can write your own case studies. You can do quality improvement. I think the real problem here is, if you want to be a research person, then you can become an academic fellow. There are posts that are advertised all the time in all the universities. They're looking for academic fellows. You can go and become a part-time academic fellow, do a wonderful salary job, go and join research, become a lecturer. There's Anglia Ruskin. There are so many universities now with academic general practice departments. They've all got jobbing GPs that do 2 days, and they've got a postgraduate certificate or a master's in medical education. And that's a very valid career choice. A lot of women do that. A lot of men do that, because it gets you 2 days out of the shop.
Yeah. Yes, I agree. Yeah, and like I said, that fourth year fellowship, you can use it to do this. HEE, that's the deanery, are very keen to support people who are innovators, entrepreneurs, people who come up with ideas, how to, add things you can add to the NHS NHS records. They're always open to this, and they will fund they give you bursaries so that you can apply for things like this to support you. With regards to research, if there are different stages. If you want to be the principal investigators, that's what we do in primary care. So Oxford will come up with the research idea, and we will just be the ones who will get recruit the patients and administer whatever interventions that are needed. Well, but when it comes to you coming up with the research ideas, I think then you have to, they call them NIHR. That's the local. So once they know you're that involved, they can kind of help you develop those ideas. So there's scope for all these things. Yeah, there's scope.
Actually, a couple of people asked, I'm not too sure if they were just confused. What are deaneries?
Okay. So here in Essex, we have ours is called Health Education East of England. So that includes, so the whole of the UK is broken into about 8 deaneries. So each of those deaneries controls medical education, nursing education, anything that's to do with medicine. Everything is based within those deaneries. So if you Google it, for example, HEE, you'll be able to see all the different specialties involved. So hospital, general practice, we all are under that HEE England. So they are the ones who will be responsible for your training. And of course, they will then liaise with the GMC to make sure that you've acquired the right level of quality, that training is of the required quality. Yeah.
Amazing. Also, so I think this one's for you. Somebody asked, what e-portfolios do you recommend for us to use, and can you use them as medical students?
Yeah, e-portfolios. These are like as you said, just an electronic diary. So I'm not sure whether, I know in the UK, all university use the NHS e-portfolio, which is paid for by, once again, those deaneries. Yeah. So as soon as you become a medical student, you get a login into that. Okay. And you qualify, then they move you into the next one. There's a different e-portfolio for when you qualify. Once again, that's also paid for. And of course, when you then become a consultant or a GP, then they stop paying for your portfolios. Then you can then use whichever portfolio you like. But as a junior doctor, it's all going to be given to you, and you use what they give you. You will have training on how to use it as well. So it's just a diary that holds all your educational attainments, all your quip, your research, everything you've done gets kept in this electronic diary. So you can never lose them.
Amazing. What can you expect from the different stages of your training as a GP, and what are you mainly doing or able to do in those different stages? So for example, in like your 4th year of training, what can you do, or what does it really consist of, I suppose?
Okay, so like we said, so in the final year, that will be usually spent in general practice. So the first year, you'll spend most of your time in hospital. So final year, you'll be in the general practice, and what we're aiming for is to see you performing like a general practitioner should, like an independent general practitioner. That's the acid test for you to be able to perform like any other general practitioner. A good quality general practitioner, I must add. That is what we're aiming for. Yeah. So when you come into general practice, I don't know whether this was the question you were asking, you will notice that the time a GP sees patient is very short, as opposed to when you're in hospital. Now, that is something that's born out of years of experience. So when you start in general practice, we usually give you 30 minutes per patient. And when you're then going to become a GP, we expect you to be able to do that same thing in 10 minutes.
Uh-huh.
In fact, that's the standard for when you submit your videos, they have to be done. Your videos have to show you've completed the task in 10 minutes. It can be done. It can be done.
Are you sure?
Yeah, it's easy.
Yeah, 10 minutes is not a lot of time.
Yeah, with the right training, you'll do it.
Training. Okay, so a lot of people were asking about WAST training. I think it's written somewhere, widening access to specialty training for international graduates.
So is that in relation to general practice or in relation to other specialties?
I'm not too sure. No, it was just about good 2-3 people asked it, but I think they're not from the UK, probably why.
Yeah, but go on.
I was going to ask, just a follow-up question. In terms of you being in the hospital in first year as a GP and you being in a GP practice in your 4th year or your final year, when does that transition happen for you in your training?
Okay, so usually everyone starts either in July or for an August start, or some people start in February, depends on their stage of training. So, and the posts are usually 6 monthly posts. Okay, so hospital 6 months, then the next hospital 6 months, then the next one 6 months, and then after each ALCP, like I mentioned earlier on, which is your this is the progress report to show that you're doing well, then you can progress to the next step. You see, so all these things are monitored. Then you're able to. So you start with what they call it ST1, and then you put ST2, and then ST3, and finished. That is so. Those are the stages of progress in general practice. Regarding the widening access, I think in terms of general practice, widening your scope, there is also the possibility of doing other things while you're doing maybe ST3. You could start doing your qualification to get occupational medicine qualification. I spoke about women's health, doing coils, implants, because this are extra bits of training you have to get, extra certificates you have to obtain. So you can start applying for those and doing those exams. Minor surgery, those are things you can do while you're in your STEs, or you could wait till you're finished and then you can. So the choice is yours, really. Yeah.
Amazing. I think the other question I think this one's from me actually, because I've talked to a lot of specialists. And every specialist I talk to at one point or another when I'm working with them, they always turn around and say to me, I wish I became a GP. So I just wonder, is it the same feeling on the other side? Like, do GPs wish they could become specialists? Because that's a big thing for students. They feel like they'll be missing out.
Okay. Personally, I don't regret my choice of becoming a GP, because I like being my own man, my own self. General practice allows you the ability to do that, especially if you are a principal. If you become a salary GP, it's a bit different. Yeah, because then you're beholden to so many other things. I'm sure Dr. Rasheed will back me up on this. So general practice, as long as you do things right and you fulfill all your contractual obligations, and when they CQC, as Dr. Rasheed said, when they're and they're happy with you, that's it. You see, so that's all. That's as opposed to when you work in a hospital, which I don't know. I mean, the hospital allows you to hide, because most patients, when they go to hospital, don't even know who they've seen, you know. You know what I mean? So in general practice, responsibility, it's all the time, because they know you. So if you kill them, they will say, oh, it's that guy that killed that mom, you know, which is why you have to be you have to take your A game with you all the time.
No, honestly, I'll tell you what, GPs are probably, I used to think that because I was a hospital doctor and I used to think GPs do back pain and sore throat, but GPs are actually some of the finest clinicians I have worked with in my life. They are the most astute people that I have met, highly intelligent, very skilled. There's absolutely, I mean, you know, I have no regrets being in general practice, and I cannot, I mean, I did many years of hospital medicine before I became a GP. And I think on those 17 years, I was pretty burnt out. By the time I left the labor ward and I left surgery, I think the only thing I missed was operating. I do not miss the hospital culture. I don't miss the pressure. I just love being a GP. It actually transformed my life. It was the best decision God made for me was to take me into general practice. So, I mean, I just think anybody who goes into hospital medicine, and if they're doing well, that's well and good. If you've got a burning desire to be a GP, a hospital doctor, but the family life balance is excellent in general practice. When I applied for my post, they actually asked me in the interview, they said, why? Because I was a year from becoming a consultant. And they said to me, why do you want to be a GP? And I said, actually, I want to do the school run. I want to be able to pick my children from school. I want to be able to spend time with them. And they all laughed, but that was actually the reason I thought I'd had enough.
Yeah, I can imagine. I think one thing I remember my father telling me is that, you know, being a doctor is not where it used to be. In anything, if you're a specialist, if you're a GP, wherever you are, it's not what it used to be. People have this very sort of traditional picture in their head of what it means to be a doctor. And the truth is, it's not even going to be like what it is right now. Because by the time you actually get there, it just evolves so fast. And I think, you know, with evolution being mentioned, I think with the next question really is, how has the pandemic affected general practice as a whole? And also, what permanent changes will we be seeing in general practices all over the country?
Reshma, do you want to do this or?
Okay, so basically, and Dr. Salako will back me up, a common misconception here is that when COVID came, all the GPs went and curled their toes and they sat at home, and I was painting my nails and going to a spa. There wasn't a day Dr. Salako and I didn't go into our surgeries. There wasn't a day any hardworking GP that I know has been there on the front line, working, vaccinating. Not a day did we stop. The only change I think that has come, which is actually quite a good research topic if anybody wants to look into it, is how we've rapidly, within a day, literally within a day, we closed the doors and we went to telemedicine. Within a day, we got given a few apps, and GPs are so resilient. They are so brilliant, so intelligent. The way we transformed care was just absolutely amazing. I mean, Dr. Salako will tell you. I'll let him tell you his experience.
Yeah, thank you very much, Dr. Rasheed. I tell you, this telemedicine has been something that a lot of us have resisted, but with COVID, like that, we just had to start buying cameras attached to our desktops and started using this. Of course, we still had to do some home visits for some of our patients, and with your, at times with your hands in your mouth, please God, I hope my FFP3 holds, that's the mask you wear, So yes, it's been a harrowing period. Now, some people will say, yes, because we shut the doors, appointments weren't being booked. However, patients were still making telephone calls, and those telephone calls have to be dealt with now on the same day. Before, when you make a phone call, you'll be given an appointment, say, in a week or 2 weeks or 3 weeks time. But now everything arrives on the same day, gets dealt with on the same day. So that's brought its own new pressures as well. And of course, the letters from the hospitals, because the hospitals too are not seeing patients. So they will talk to the patient, and guess who they're going to ask who to do the bloods or to do the injection? It's the GP. So that has brought all these pressures on Paul general practice. But thankfully, thanks for the as I would say, we don't say it often, the CCGs have been helpful. They helped us with something they call the respiratory hub. As you know, COVID causes chest symptoms. So we do have a dedicated hub in our local area. So when the patient is actually kind of coughing and spurting out the virus, you can take them to a dedicated area where it can be contained and they can be seen face to face. So those are the kind of things that helped improve our resilience in the area. And of course, as Dr. Rasheed said, we kind of clubbed together as PCNs and federations to work together. We have something called extended hours. We can send our patients at times when we're a bit short-handed, or some practices they might have one, or maybe it might not even be the doctor, it might be their wife that's gone down with it, then they have to isolate. So that's kind of helped keep the business going and keep a healthcare so that we can deliver healthcare to patients. Yeah, but it has been a difficult one. And more importantly, we have been successful in the area in getting, and I'm proud to say, vaccinated our share in the local area. It's something I'm proud of, that myself and my colleagues, especially Dr. Rasheed, have been able to achieve, and we can raise our heads with pride for.
Dr. Salako is an amazing colleague. I've known him how many years now? I think, what is it, coming up to 25. So
Right.
we're kind of growing old together, but we are very good colleagues. We work very well together. So he's a real treasure. Lovely colleague to have, great partner to have.
Thank you. Thank you
so much, doctors. In terms of how this is going to reshape the way general practices conduct in the future. So like Dr. Salako was saying, you guys start using that telemedi, or just virtual consultations.
Yeah.
Will we still be seeing that after the pandemic?
Yeah, definitely. It's here to stay. Yeah, it's here to stay. It had already started before the pandemic, but some were just kind of resistant to it. I mean, London, they were doing loads of this, but now it's here to stay.
And I also think, Dr. Salako, this was a real wake-up call for the patients, because what we found was almost 95% of everything that we were doing face-to-face, working in an unhealthy environment, patients coughing on our face, us going home sick. Every winter, I'd have 2 or 3 chest infections. Nobody fell ill, and we were able to manage. And now patients have learned through this bad experience that actually they can access their GP, and it's okay to be given medication on the phone, because we know them from birth to death. We have their whole record, and they call us all the time. So we are quite confident managing them. So I can't see us going back to the old-fashioned way of working. It has actually been such a gift, if one can say that, that we, and you know, as GPs, we were able to extract the best out of a bad situation.
Absolutely. And I think a question a lot of people ask me to ask, a lot of non-medics actually, what's the situation with the lockdown? Because everybody's wondering, you know, is the pandemic where it is right now getting worse, getting better? Are we? How does it look? Because I feel as if GPs are the people who are most aware of what we're dealing with and the future events of it. So in terms of the pandemic, are we still in a really bad situation? Is it getting better? Could we expect lockdowns to ease up in the near future?
So I think we're at level 4. So the R rate is running somewhere between, last when I heard, 0.6 to 0.9. So it's just bordering under 1. R rate is the transmission rate. The last count, I think we had under 1,000, about 900 fresh cases were diagnosed. So the rates are still high. But the vaccine is definitely making a dent. So the government is on the road to opening the lockdown. So we're expecting by May or June that things will be restored to normal. But it's possible that come winter, September, we'll have the flu surge, and the virus is mutating. So wearing a mask, good hygiene, social distancing is here to stay. And it's a good thing that it is.
Yeah, I agree 100%. I don't think I would ever see anyone with chest infections without my mask in the future.
Absolutely. I think, you know, me and my friends were theorizing the other day that, you know, it's just going to become a thing now, even after the pandemic. People are still going to be wearing masks, or asked to at least, in public places. So it's definitely reshaped our society, and in terms of how we're moving forward with that. Okay, so the rest are just quite personal questions, really, in terms of how you guys deal with being a GP. I'll give you an option to pass if you don't feel like answering any of them. But it's just really like, what's your worst day as a GP? What is a bad day?
When you get a complaint. When you get a complaint, it's your worst day, and people will write in sometimes with such awful letters, and you look at it and you think, I'm not that person. I didn't say that. I didn't mean that. But what it is one of my colleagues called it a public toilet. People are angry. We live in an angry society, and they hold GPs in very high esteem. And I think when things don't go the way they want them to go, they just come and they vent at us. And you have to see it through. You just have to see it through. Everybody gets complaints. You learn to handle it. And if you're in a good, well-supported team, you know, you can go, like I go to my other senior partner. He's been a GP over 30 years, and I sit down and I talk to him, and he says, yeah, Reshma, these things happen, and you know, you've got to let it go. You've got to just let it go, and you've got to move on.
Yeah, I agree.
You see, Dr. Salako is a very popular GP. I'll be very honest over here. You know, they love him. So all he gets is boxes of biscuits and chocolate and praise. So he never sees any complaints. Let me be honest, Dr. Salako. They love you. I've seen your patients. They will wait 4 weeks, 4 months. If I say to them, he's not here, go away. They will be standing. They will be in a sleeping bag outside your surgery waiting to see you.
No, as Dr. Rasheed said, it's true. When you do, you do get complaints, and kind of, you know, but as you said, you can't please everyone. So you just have to, one just has to grow a thick skin and make sure you handle it properly and learn. If there's any learning for me, to make sure you learn to try and avoid this going forwards. Yeah, we do get bad days. I mean, for example, last week, my team, Tottenham Hotspur, lost to West Ham. That was a bad day because I got ribbed by all my colleagues. So that was.
Here's an interesting one. Because this is all because we were talking about, you getting through a patient in 10 minutes, 10, 15 minutes. So how do you deal with a difficult patient? Let's say, you have a lot of old people coming to you, a lot of lonely old people coming to you. They just really want someone to talk to sometimes. So, and you're on a very, very tight time to have a full discussion with them and see their symptoms and try and get a diagnosis and prescribe the medication, then explain to them how to take that medication and so on and so forth. And so how do you guys minimize the small talk while still keeping your manners and being polite and all that stuff? Because that completely blows my mind. I don't know how
No, that is one of the difficulties of this job. You see, you are allowed to spend more, at times you find you spend 30 minutes with some patients, but you try and make up with it, because then the next patient might be somebody that's just got a sore toe. Then you try and catch up. But yes, if somebody needs time, you have to give them time. This is one of the things we've learned with COVID, because you triage everyone. So you're able, people like you just mentioned, you would have taken all the sting out of it on the telephone. So you don't need to see them, or you dealt with everything, or if you need to, it will just be for a very limited period of time, because you spend all the time talking about everything else on the telephone, you see. But yes, even though we say it's 10 minutes, but not everything is 10 minutes. There are cases that can take you an hour. I mean, if you need to section a patient, oh my God, section is when there is a mental health issue. By the time you called on all the necessary authorities that can help you sort it out, it could be 2 hours, and it's not everyone works in 10 minutes, or you get.
What you also do is you call your colleagues for help. What you do is you don't try and deal on your own. If you're in trouble, your clinic is running over, you just send a message to reception. You postpone some of the appointments, because patients are very understanding. You can speak to them in a day or two. And then if you say doctors had an emergency, then you schedule a slightly different type of clinic. And then if there are patients that will need, because they have learning difficulties, they have communication difficulties, then on the record, they usually put a rider which says this patient needs double appointments or triple appointments. So then the doctor is scheduled for that. Patients are very understanding, and it's a mixed bag. So you just reschedule your clinic, tell the reception, get by yourself some time, but your customer is always right. You never cut corners in a consultation. Once you're in a consultation, you do the job. You finish the job, you do the job. You can't go in a court of law and say, well, oh, I was running behind, or I had 20 more patients. No, that's not that. And that's where being with supportive colleagues helps. So I do it all the time. If I'm doing something complex, I'll send a message. Somebody else will pick it up. We move on.
Yeah.
Could you get reprimanded for that, by the way, if you're a normal GP by your senior? If you keep going over the 10 or 15 minutes, taking a little longer with your patients, and then even having patients at the end of the day you're supposed to have seen, and you've not got around to, and now it's like 5, 6 o'clock.
I don't know what Dr. Salako does with trainees like that, because he gets the trainees, and I don't know what to do. What do you do, Dr. Salako? You sit down and have a kind word with them. You're a kind man, so you're going to indulge them, aren't you?
We do have a gentle word, because that could also be a sign that maybe you're struggling. Or the issues, because we're all human beings. Might be that their mind is not there. They're thinking, So those are the amount of things you come up with when you have these gentle words with people. And then once all these things are sorted, then they just get back. I mean, I've had trainees like that who always running behind patients, then end up complaining. But it was because they had they have children, the husband. But as soon as they are able to verbalize these things and you're able to get the necessary help in, they just kind of pick up again. You see, because at the end, these are very clever people, they've all had A stars, got all this, but when life gets in the way, all those things don't matter anymore, you see.
And you build blocks. That's the other thing. If you know somebody is running behind, you build blocks. And sometimes what I do with people that tend to do that, I just filter the difficult patients to myself, because what you don't want with a doctor already having struggles is to burden them. So most people are very supportive of their colleagues. General practice is working in a big family. You just have to tolerate each other and get on with it. That's how it is. It becomes your work family. That is why being in partnership with like-minded people is a joy. It's a real joy coming into work, because you're the team, and really GPs don't deliver care singularly. We have a huge team supporting GPs. So as I say to my people at work, it's the team of the day that delivers the care, and any triumph is your triumph. If you've got a box of chocolates, it's because the team was there right from the receptionist, right from the nurses, the people who work at every level in the general practice. They take credit for it. There's no doubt. Some of the people that work with us are just amazing.
Absolutely. Okay, I think we've pretty much, gotten through most of the things. There are some other questions, they're not very relevant, so I'm going to skip them out. And I don't so we're just going to jump over them. Before we finish, I just want to thank Dr. Rasheed and Dr. Salako for being here. It means a lot. Thank you for, dealing with me. I know I've been pestering you and bothering you with calls and messages and whatnot over the last week. So thank you for dealing with that. Incredibly patient people. I kid you not, no matter how many times I call them, like, they might not answer, they'll always call me back. When they always call me back, they won't be annoyed. And they'll never hang up the call first. I've always noticed this, like they're always like, wait until like I'm done, I hang up the call. They'll be like, all right, cool, that's the end of the conversation. So I've had a super good experience in myself, and to the point where me and Dr. Rasheed are even thinking of setting up a primary care society, and sort of pushing this education even further, because I know we covered a lot, but there's so much more detail we can go into. There's so many more little things, and even not just information, but for educational purposes, where we can try and deliver that training just to give people a bit more of an insight and opportunities. I also want to thank the doctors just for being frontliners, really. They've done us great service, and really with the conditions of the country, like, imagine how bad it would be if we didn't have doctors like this, as bad as it is already. So really, they're keeping us.
Mohsen, you guys are going to be looking after me in my old age, so you better be studying hard, and you better become very good GPs, because when I'm old, I'm going to ring you every week, because my memory won't be good, and I won't remember lots of things. So I want you guys to work hard and come back and become good GPs, because this country needs you.
Absolutely. Again, thank you so much for being here, to all the participants, to all the attendees. It means a lot. I hope you guys have filled in the feedback form. It's in the Q&A, in the answered questions. It should be somewhere in there. Just keep scrolling if you can't find it. Just fill in the forms. You guys will get your certificate for attendance, your electoral discount codes. Put in your number. We're giving out a lot of free passes this month. And so on and so forth, and also give us a follow on our social media, because that's the thing, like, a lot of people tell me a week after the webinar, like, do you have a recording? Like, I missed it, I didn't even hear about it. And I'm just like, you don't follow us on social media, so it's just, how are you going to hear about it? So please follow Study Medicine Europe. It's over here. So Study Medicine Europe, you'll find it on Instagram, you'll find it on Facebook. And we just post everything over there. Usually, like, this one was posted a bit late, or a couple of days before, but like, usually we try and aim to get it 1 week before. But it's February, so yeah. Thank you so much, everyone. I'm just going to leave this call open, because just so people can access the feedback forms, and I will leave it over here.
Thank you, Dr. Salako. Thank you, Mohsin, and thank all the attendees for being here. And by all means, you can get my email address from Mohsin, and we're here to help you in whatever way we can, because part of our Hippocratic Oath requires us to transfer knowledge to the next generation of doctors. So, you know, we are here to support you. So don't hesitate in coming back and asking us for more advice. I'm happy to do that for you.
Absolutely, what Dr. Rasheed said. Just feel free to message me if you're really interested in becoming a GP and going down that route. We are going to start something soon that will be more official. But feel free to reach out to me and express interest, and I'll just put you in the group, and you know, we have a group of people we can get started with. So thank you.
Thank you very much.
Thank you. Thank you.
Thank you, everyone.
Thank you, everyone.
Bye-bye.
Take care.